Well, welcome to the nursing section focus corner. It's really good to see everybody, see people's faces. Sorry we don't get to get together this year in person. And I just wanted to really say I appreciate everybody's participation. The nursing section is really an open forum. We are here to support each other and try to engage in discussions, and which is exactly what we're going to do today, and share resources and ideas. I'm Karen March, and I'm the section chair. Catrice Nakamura is my co-chair. And so wanted to get started. One of the ideas we say is, we're here to share information and ideas, and the nursing leadership for the nursing section, we had a discussion about what it was we wanted to talk about this year, and it was pretty much unanimous as we got started talking that people wanted to talk about their experiences with COVID. It really, I think, has engulfed our lives. And I kind of looked at the statistics today just before I got on from the Johns Hopkins website. We are just approaching 30 million cases with close to 950,000 deaths now globally. U.S. is a little over 6,669,000 cases with, we're almost 198,000 deaths as of today. And Brazil, since we have Renee here with us, they are 4,420,000 cases and 34,000 deaths. So it's a big problem, and we don't seem to be getting any better. The idea today is we're going to share information about the different roles and how nurses have been involved in the COVID, dealing with COVID. We want to discuss individuals' experiences, both with COVID and anybody who's had COVID, and also discuss what we're seeing in the neurologic sequelae. And ironically, there's a lot of things that we're seeing. And just this past week, we've had one of the COVID vaccines put on hold for a neurologic complication, patient with probable transverse myelitis. So I think it's all very timely. So with that, I want to turn it over. Mary Kay was going to share some information about an article that she was part of in putting together some information. And the idea is we have several people who are going to share their experience to sort of get things rolling, and then we want anybody else to chime in.
So like all of us, I was at the March 8th, 9th Board of Directors meeting, going about my business, and then came back to work on March 10th, and lo and behold, poof, everything just blew up. And as a clinical nurse specialist, this neurocritical care, I thought to myself, boy, I got to learn about this, how do you manage ICUs in a disaster, and how are things, going to impact the ICUs? So I literally developed a PICO question, did a lit search, and spent the entire weekend, like Friday, Saturday, Sunday, reviewing the literature and educating myself on different disaster modes and what happens when you run out of ICU beds. And so when I came back to work on Monday, or on that weekend, I was texting the director of critical care and the physician, I said, you know, we got to get prepared for this. Even though we'd only had a couple cases, I said, this could turn bad real fast. And so I said, you know, I think we should meet on Monday. And he goes, oh, no, let's meet at the end of the month. And I'm like, I think that's going to be a little too late at the end of the month. So what we did is we got together. I pulled together a multidisciplinary task force, physicians, intensivists, infectious disease, hospitalists. We had ED, we didn't have ED docs at the beginning. It was just respiratory, pharmacy, nursing, and critical care. And we started to meet 3 times a week. And so this article that was published in Critical Care Nurse Online August 17th, it'll come out in print in December, was actually we submitted it at the end of May, and they published it online in August, which is pretty amazing to go through that process. But hopefully maybe there'll be some things that I'll just go through quickly that may be helpful, and I am more than happy to share anything I have. I can share the article. I can send you the article if you don't have it. So it was co-written with my colleagues in critical care and also hospital administration, the chief nursing officer, and the doctor in charge of the COVID-19 task force on a hospital-wide response. Dr. Panicello and I were we are the ones that, let's see if this will go, we led the critical care response to COVID-19. So just to give you just an overview, as a CNS, I'm always approaching things through an evidence approach. And since I knew like nothing about pandemic responses, I had to educate myself. So here's the PICO question. How does a non-academic hospital ICU apply pandemic and COVID-19 management guidelines to optimize readiness, maximize resources, and treat patients during the peak surge of COVID-19? So I actually had 25 articles that I reviewed. I'm not going to go through these. These are in the article that was published, and I have the originals. So if you're interested in them, I'm more than happy to send them to you. We use the Johns Hopkins evidence-based model to grade these articles on their evidence. And it even included Society of Critical Care Medicine had a great bunch of videos on their disaster response and how you should manage disaster and triage, which I found very helpful to learn about, you know, how do we manage when we don't have enough critical care beds or we don't have enough ventilators and things like that. So we created this task force. We met 3 times the first couple weeks, and then we went to like twice a week after that. And in the first week, it was all the people that you can see, the intensivists, hospitalists, those individuals. But it was interesting because I was just looking at critical care response, but then the ER docs heard, and they're like, well, we want to be involved. And then Children's Hospital heard, well, we want to be involved. And then trauma wanted to be involved. And then the next thing I know, within about 10 days, I had 47 people on this task force because they were all interested, including palliative care, epidemiology, director of quality. So it quickly exploded into a large group, but we did via team meetings. That's how we had our meetings. So we're all socially distanced. And we actually adapted the 2014 CHEST consensus surge capacity model. There's a great paper published by Hick et al. In 2014. And they make it simple. And I'm a simple person, you know, so space, staff, stuff, and system strategy. I can think that way. And so we set up our meetings. And I can tell you, you know, sometimes my physician colleagues, as greatly intelligent as they are, you get like 30 of them in a room and they're all over the place. Like, I want this and I want this. And so I kept pulling them back. Let's talk about space first. Let's then talk about staff stuff. And so every meeting started with this template. And the template in the CHEST consensus model uses conventional, you know, you're in conventional mode when you can deal with the number of patients you have for critical care. You go into a contingency mode when you've exceeded your capacity by 100%. So we had 51 critical care beds. We had to add 15 critical beds in an old ICU that we brought back to life. We had to go to our NSI PACU and convert it to a critical care unit. So it looks at how you expand spaces that normally are not critical care units, and how do you make that a critical care unit functioning, and then, how do you manage it? Crisis means you're expanding your resources by 200%. And when you're in crisis mode, systems often are overwhelmed. But by using this approach, we had we talked about what areas would be converted next, or which ICU would then switch to a COVID. So we had a interventional ICU that was 15 beds. That was the first COVID ICU. Then the cardiovascular ICU became the second COVID ICU with 27 beds. And then, how do we look at the neurotrauma surgical ICU? And when do we convert that? So it was having this sequence. And then we also designated non-ICU areas. So we actually cordoned off 1/3 of the hospital, and that became the COVID area. So there was no cross-contamination. So that's space. Staff. How do you manage it when you have now more critical care beds? You don't have a lot of nurses. And so I was tasked with taking a look at different models, and SCCM as a model I'll show you in just a minute. Supplies. Do you have enough ventilators? Do you have enough IV pumps? Do you have enough medications? Do you have enough supplies? I mean, all of those things had to be considered. And then system strategies, how you manage critical care patients. We all know how to manage a patient in ARDS, but these are new disease processes, and how do we manage a cardiac arrest in a COVID-19 environment? How do we manage stroke in a COVID-19 environment? And so creating evidence-based protocols, that was my job. I was creating these guidelines and these protocols with the physicians, with the team members, pharmacy, respiratory, everybody, so that we all were on the same page. So this is just showing you sort of the summary of the space and how we expanded the staff. And I'll show you the model we used. So the SCCM had created a model that looks at a 24-bed ICU. You would have 4 ICU nurses, and then you would have 12 non-ICU nurses. So they had this model that we then broke down into a contingency and crisis staffing. So because we're in California with ratios of 1:3 or 1:2, you can't have more than 2 critically ill patients. When we went into contingency mode, an ICU nurse would have 3 patients, but she would also have a med-surg nurse or a non-ICU nurse working with them. And if we had crisis mode was 1:4, so 1 ICU nurse, 2 non-ICU nurse, 4 critically ill patients. And a crisis mode of 1:6 was 1 ICU nurse to 6 critically ill patients with 3 non-ICU nurses. And I actually worked with the charge nurses and bedside nurses and created, what are the ICU nurses' documentation and care priorities versus the non-ICU nurse, so everybody knew what their role was. So this was something that I was responsible for doing. Supplies, making sure ventilators were a big thing at the beginning. We never ran out of ventilators. We were actually able to double our supply of ventilators rather quickly. We always had a shortage in PPEs like everybody else. Testing still a disaster. We still don't have enough tests. We get 60 tests a week. I don't know how the NFL is testing, thousands of players and thousands of tests every week, and we can't even get more than 60 tests in our hospital. Pharmacy, we had shortages of sedation drugs, analgesics, neuromuscular blockers. How are we gonna ration that? How are we gonna change? What can we use? So we had to deal with that on 3 times a week. We're talking about it. And then the system strategies, which had to do with really, developing a whole new process for cardiac arrest, a whole new process for stroke patients, new ketamine sedation protocols, new protocols for drugs for analgesia that we might not have used before. So that was all part of the process. And this is an example of a COVID-19 algorithm that was part of our COVID-19 cardiac arrest. Part 1 of that guideline was all about the ethics surrounding how the the doctor communicated with the patient and family on determining whether that patient would want compressions and a full code if they were COVID-19 positive. And so, you know, we created PPE boxes so that they were in every unit so that the team would have the N95 and the face shield and the gown and all the things that they needed in a box readily available. We created signs that were laminated that allowed the staff to hold it up because they're inside the room and we couldn't hear them outside the room. We also had a protocol that looked at how we went, you know, if you came into the ER had a separate algorithm. Compressions stopped at the doorway if the patient wasn't intubated in the pre-hospital setting, and because they couldn't be bagged down the hallway, and compressions spew virus. So, you know, they would come down the hallway quickly while they're on the ER gurney, they'd be intubated, and then compressions would start. So lots of things that had to change in our practice. We even developed a limited resource for mechanical ventilation algorithm. This was our code stroke algorithm. So, you know, the neurointerventionalists were very stringent on patients coming in. They would not do the interventional procedure unless the patient was intubated. And they made that decision early on. So if the patient came into the IR suite and they were not intubated, then anesthesia would be called. They had a negative pressure box. Everybody in the room had to wear the appropriate face shield, N95, et cetera. So, you know, even looking at how you were managing stroke patients. But that task force enabled us to deal with these issues, and the physicians were highly engaged during this process, which was, I think, it was one of the good things about our experience is that they were fully engaged in, I would present the literature, cytokine storm, whatever it was, and they would read it, they would come, they would talk, they would argue, they would come to consensus. So this is the article that's published online ahead of print. And I don't know if anybody has any questions about it, but I'll stop sharing and turn it back over.
Thanks, Mary Kay. Laurie Madden, would you share your experience?
Sure, although I didn't make fancy slides like Mary Kay.
That's okay.
So I'm at UC Davis in Sacramento, and we set up a command center. I was, at the beginning of March, I went to a grade workshop in Phoenix. And I'm co-chair of the guidelines committee for NCS. And so I went to that workshop just at the start of things. And then a couple days later, I went to DC for another meeting for kickoff for something called Magnet for Europe. And right after I got back, I was asked to quarantine and get tested by my institution because of travel, and I had some allergy symptoms. But right after that is when, or during that time is when our command center was stood up, and we all started to look at figuring out about preparedness and looking at a surge level. We define that based on our capacity in the ICU, and similar to what Mary Kay was referring to, we looked at models of what was developed in other areas and what resources there were, including SCCM. And as Mary Kay noted, we're in California also. We looked at the fact that we're fortunate to have ratios, but one thing of note is that there's a waiver during pandemics. And so the state allows for a change in those ratios in that scenario. So we had to quickly look at standing up new spaces for ICUs and for acute care floors too, potentially. And so preparing nurses to move into those settings that aren't traditionally practicing in those areas. So we looked at the model for SCCM and considered where we might be able to get nursing staff from and looked at, we don't have nursing assistants here at UC Davis. We're almost 100% RN staffed hospital. And so we looked at a model from another UC. At UCSF, we had patient care assistants, and they still do there. But so we used that position description to identify activities that a non-ICU nurse might perform within the ICU and within the medical surgical setting, and put together a list of skills and worked with our educators to develop a curriculum for staff from areas such as the clinics and information technology and case management, all the areas that don't have acute care practices. And because our outpatient practices were cut back a great deal, we were able to bring them in and have them go through training and shadowing in different clinical areas so that they could have an experience prior to any need for us to scale up. Part of what we developed was a skill sheet, and we figured that we needed to have something that individuals could bring with them on the day that they were deployed and bring it to that clinical area that could demonstrate what their skill set was, and it might also prompt the clinicians in that space to identify, oh, I can ask this person to do X, Y, and Z. So we developed a sheet that we had multiple versions of over time, but identifying what practices they felt competent to perform. Part of that was informed by the shadow days that they had or their prior experience, and we tried to look also at the roles that people had before they might have moved out to those other areas, like educators that previously were in the ICU, like in the last 18 to 24 months. And those people would have an easier path toward being able to perform activities within the acute care ICU setting. So we set all of this up and got it ready and never had to deploy it thus far. So we didn't publish anything like Mary Kay and team did, but it was an interesting process. We built up this whole curriculum and this training program and this format, and had spaces identified that we had identified for new ICUs, and had providers who were set up. But I was in the group. We figured out about the nursing at the bedside and what that would look like. And then we quickly shifted to figuring out how to set up screening for patients and staff and visitors for getting into the institution. And so it was a dynamic environment. I don't have anything more to say. I know that we're all on similar boats and have done similar stuff, so I'm curious to hear what else everyone else has.
Yes, I want to skip around. Renee, we'll go outside of the U.S. and get a little experience.
Yeah, sure.
Welcome from Brazil.
Yes, thank you for the invitation, and it's a pleasure to stay connected with you. But well, in the beginning of this section, you presented the Brazil numbers. Fortunately, this number is bad. We have some problems here, but even though these all level problems with leadership, president, the nurses are struggling to cope with. Yes, it's hard to talk about the nurses in Brazil because it's actually and heterogeneous practices. But I told them with nurses places here in Brazil, and I realized that we have the same that you. Yes, but here in Brazil, the first problem is the number of ICU beds, because we have 8 numbers, but of distribution of these beds is not uniform. We have a lot of ICU beds in the centers, but counter-side's the problem. And another issue that nurses need to lead, it was about the qualified nurses. In Brazil, we have the different kind of the model of care. We have the proportion of the nurses. It is usually in ICU is one nurse, registered nurse of nursing is like a LPN, one for two patients. And this the model of care, especially for this very severe patients, we need technical nurses and nurses that haven't experienced for these patients in hospital. So we need to learn the basic techniques, assessments. It's a big problem, plus the complexity of these patients. To learn new nurses to how to care these severe patients, it was a stressful for nurses. Yes, in Brazil we have problems about burnout and the workload of nurses in ICU. So this is the main problem. Another problem that you need to lead, it is about PPE. Yes, because we need to use them, have the smart use, but it's not easy for us to give access this kind of PPE. Yes, of course, like me, for example, here in São Paulo, in the big city, big states, we don't have this problem, but in places in Brazil, it's a big problem for nurses too. And another kind issue that nurses need to lead is about equipments. We have a lack of IV pumps, ventilators. This is a problem that nurses need to solve, to treat this, to care these patients. So we can see that nurses demonstrate compassion and desire to choose patients, but to lead the daily problems in ICU, we have can realize that we have increased the number of adverse events in ICU, especially related to medication and the patients, some problems with vasoactive drugs and sedation, because nurses don't have ability to titration this type of drugs. So especially for nurses like me in position that charge nurse, we need to work hard to learn and to give assistance for nurses to care these patients. Now we believe that we are in the plateau, but the number of the cases is more not relaxed, but more peaceful time. We can manage the situation better, but we have problems to solve from, I believe, that more months, because the number of the cases is higher. It is it. Thank you so much.
Deborah, Tran, do you want to share your experiences?
Yeah, so mine is very different. Can you hear me? So my husband is actually a nurse as well. He's the supervisor of our COVID ICU. So I'm in Texas, and we actually have another very unique experience. We were the first hospital to have Ebola. And so we were very well prepared with PPE. We were not going to go down that road again. But that's actually not why I wanted to talk. I wanted to talk because one thing that we really noticed was the symptoms, the neurological symptoms with COVID. So while I've been administrative supervisor at 2 different facilities, we definitely had all of those different task forces. We had lots of planning. How are we going to use our resources? Laurie and I actually had mentioned about, a good topic of conversation when we had our planning session was maybe how the neuro nurses felt about going to a COVID unit, because that's definitely a perspective as well. So, but really what I wanted to talk about is, so one of our very beloved surgeons actually developed COVID pretty early on, and we had some really good success in the beginning. Our hospital is very well known for our ability to deal with pulmonary diseases, despite Ebola's press that we got, and also sepsis and that sort of stuff. So when he became very sick, we had actually had about 7 patients at the same time who were on the ventilator, were proned. We were using the rotoprone bed for some of the patients. And we actually found one that manual proning actually worked much better than the rotoprone bed. So our patients who had just the manual proning, we went through and taught a lot of people manual proning, because we found that this is just something that happened better. But with our particular surgeon, just to go back to that, he was very sick. He was on the ventilator for just about a week before they were trying to see what they can do to wake him up. He was having, just some intermittent times where they could get him to, maybe do a little bit more physical therapy, wake him up just a little bit. And we just found that his neurological symptoms were very dramatic, to the point where we had all suspected that he had a drug problem. And so we actually found this because we had like 7 patients that got sick altogether, that probably a couple days later, we saw the exact same thing in the next patient who was just as ill. So they had run all the drug screens. The other thing that they were looking at was whether or not he had an alcohol problem, because he was ventilated so long before they started discovering this that it was difficult to do any sort of drug screening at that point that would be successful at all, aside from what he was receiving for sedation to be ventilated and proned. So his behavior and the behavior of the other patients was very similar to somebody who was intubated for a long time, or when I say long time, I say 4 days without waking up. And he looked like somebody who was in severe alcohol withdrawal syndrome. So if you've ever taken care of a patient with severe alcohol withdrawal and you don't know that that's what the problem is, you start with your Ativan and your banana bags and all that fun stuff, but you're playing catch up. You have to just keep giving them more and more and more. But the problem with this is, nothing touched them. Very violent with the staff, would come out swinging. And we were using the recommended sedation products at the time. We didn't have a shortage at that time. So we were intubating him with our normal protocol. They were getting propofol, all this stuff that, was very normal that, we had seen in other patients. But for whatever reason, this particular population just had really, really bad neurological symptoms in terms of behavior. So we have not done a study on it yet, but it was something that we continued to see. As we did have some drug shortages, we wound up having to switch some of the sedation. And so we haven't seen quite as much, but we are still seeing it with every single patient that is long-term intubated, or just long-term COVID patients that are in the intensive care setting. Not all as extreme as the ones in the very beginning, but it was an interesting situation for us to see, because we've obviously had a lot of other patients that have been in the ICU long-term, whether it's a septic shock, a cardiogenic shock, and we have not seen this same behavioral issues with those types of sedations. So that was my perspective.
So Deb, I would encourage you to take a look at the NCS COVID-19 research opportunities. There are several studies about the neurological manifestations, and they're trying to collect data. It's actually from all over the world. Molly McNett, a nurse researcher, PhD, and Dr. Sherry Chu from Pittsburgh, or Chow, has been leading this effort. And so I think that's a great opportunity to and anybody can sign up, sign your center up. You can input data. I'm sure Laurie can probably talk a lot more about the research aspects. I've not joined or signed up for that. But I will agree with you on the medications. They took a lot more medications. We could not wake them up. Their pulmonary status was so bad. We've had patients on the vent for 60 days. We're fortunate we have a very low mortality. In the first 2 months, we only lost 1 patient. And in the last 7, I think there's 5 total, but the mortality has been extremely low. But they come out, I mean, we've seen things that look like that when you had the paralytic, it was back in the 90s when certain paralytic drugs, they have like myopathies, like they can shake their head, but they can't move a muscle. Like it's scary, and I've seen it take a month or 6 weeks for them just to move something. So I know, I'm sure others probably can chime in. It's pretty scary.
I think what was amazing is this particular surgeon wasn't down that long. And, you know, obviously he's just a beloved member of our staff. So that was so hard for us as well. But yeah, so we did have another patient that was on the news because they were, again, 60 days, same thing. We really did not. We were just so amazed that he came through and he did well. And, you know, but yeah, we were in the same situation with low mortality. And then we did wind up, I think our only patient in the first 3 to 4 months that had passed away was actually one that the family had decided, he was older adults and they just wanted to give him comfort care. But yeah, so it was interesting. But yeah, my husband, poor guy, yeah, he was fighting with the patients at night.
Well, thanks, Deborah. Maria, so we've got our experience from in Puerto Rico. You share you have to unmute yourself.
I'm sorry.
That's okay.
Okay, so definitely our experience in Puerto Rico is completely different from yours. We were in lockdown from March 15 up to the first few days of May. So it was a complete lockdown in the whole island. That meant that we had just a few cases. But then after May, the lockdown was done and we got many visitors from the United States, mostly Puerto Ricans that came back to the island because the airfare was around $20 for the whole round trip. So everybody was willing to come to Puerto Rico because of those cheap prices, and we got more people infected. And we had our peak maybe by the first few days of July and the whole month. So in that time, my ICU was already a COVID unit. We had 11 beds for COVID patients, and the rest of the unit was for the regular patients. At one time, we did have the 11 patients in the unit, but after maybe the first few days of August, we only have a few. As of today, I only have 4 patients. At one time, we have 50 patients in the whole hospital, which was a lot for us. As of today, we don't even have 20. So things are doing better these days. Our ICU nurses were the ones taking care of those COVID patients, and they still are working with those patients. They are definitely tired. Too many months wearing PPE. It's too stressful. So we are working also on that, on the psychological level. We did not had any help from other nurses, from med-surg nurses. We work with only the ICU nurses, so it was tough the first few weeks of the pandemic. And what we did first is, because we only have so few cases, by March we only have like maybe 4 or 5. We did that one-on-one. So every nurse just one patient. And it was easier for them to learn how to take care of those patients and how to get their PPE on and get it off. And it was like a training process. Even though we were working with patients, we were like training on how to do things. So by now, I think they're ready. They feel more secure with what they are doing. We are also proning our patients. We are still doing that. Just a few of them, not all of them. We do it manually. We do not have the bed. So we do manually for the patients that we prone. And it's been a learning process for all of us. I think the psychological strain is the worst. The physical is not that bad, but the psychological, it's definitely the worst. Too many deaths. Maybe we suffer before all of this, it was maybe one death, you know, every week or every 2 weeks or every 3 weeks, no more than that. And at one point we saw 3 deaths in just one day. So that was too many for us, and that was the difficult part. And not having their family members with them was also difficult. Too many calls from the family members just to check in, just to know if they slept well, if they are doing okay, because they are not allowed inside the ICU. So that's another difficult thing, because we were already having our family members with the patients all the time. And then to move on to not having anyone at all. So it's been difficult for both parts, not only us, but also for the family members. They are not even allowed in the hospital. We have 2 nurses that were staff in the hospital, and they got sick, and they both died in the ICU. So that was definitely really, really tough on all of the nurses, because they were our co-workers. As of today, we haven't had any physicians that were infected, so that's a good thing in one way. And it's getting a little bit easier, you know, we're getting used to it. I think it will never be easy, but we're getting used to what we're gonna be doing for the next year maybe. Hopefully it won't be that long, but you know, that's what it looks like.
Well, thank you. Does anybody else want to share their experience, or any of the speakers that have already talked, anything about what they've seen, if they've seen any neurologic patients?
I saw Yana's on the call. Does she want
Yes.
to share what's going on in the Philippines?
Oh, hi. Good morning to everyone.
Hello.
Hi, Anna.
Nice to see you all. So here, well, February, there was, well, the first case in the Philippines started late January. And then there was notice already from our Department of Health that that large conference meetings is not anymore suggested to push through. And we were scheduled to have our critical care nurses conference the end of February, but somehow we pushed through with the following strict guidelines on how to do the sanitation and stuff. So it was permitted. However, during March, there was already a mandate on preparation of lockdown because of increasing patient cases in Metro Manila. And then we were supposed to have our policy committee about the national stroke policy in the first ever national stroke policy in the country. So that was canceled because of the lockdown. And then I was allowed to fly back to my hometown, and then the Metro Manila was handling very difficult scenario about the pandemic and all. So most hospitals were out of staff, having staffing crisis, out of supplies, and even out of space. So government hospitals put up tents outside their hospitals so they can cohort and cohort symptoms of our patients. Private hospitals can have equipments better than the government hospitals, and they can have better supplies. And there was a hearsay that the N95 mask was provided more to the private because of the release of finances rather than the government one. So there was really depletion of supplies, especially for the PPE in the government hospitals. And there was no proper guidance in most government and private hospitals that led to the sort of a screaming mandate from the leaders of the different hospitals that they want a solid guidelines from the Department of Health about how to handle this COVID, because patients go everywhere. They despite the mandate of not going outside, stay at home, people go everywhere to have their checkups about if they have COVID, they have acquired the disease. And the shortage of tests in different hospitals is really, they can't do much. So what happens is that the hospitals have their different levels of care in ICU. They converted wards to become COVID wards. They converted their ER to become COVID ERs. But in government settings, they have this COVID tents only. And because of high cases of suspects, because of the urbanized, or what they call the rural settings. So patients clump up in areas. So the government converted some quarantine facilities like the hotels. So cases are quarantined there, but patients escape. So there are more surge now of cases. So we cannot control the people. That's what's happening in the Metro Manila. But in Davao City, where I was fortunate to be at home in my hometown, we were quite disciplined, because our government mandated that all COVID cases will only go to one large regional hospital, and that's where we take care of all our COVID cases. And our quarantine facilities are located somewhere with partner hotels and very far hotels outside the city that can cater the large part of Mindanao. So it was quite strategical compared to the Metro Manila. And then I'm taking masters, so most of my professors are currently practicing the transition online. So all our educations, both parties are trying to be Zoomies or Google Meet. So we are trying to deliver as much as information to everyone about our situation and all. So currently now we are easing protocols, so people can fly with certain papers on hand with them, especially the COVID testing. And also there was an issue about the use of COVID PCR test or COVID rapid test, and the government is using more of the rapid testing kits rather than the PCR test, which is more accurate than what they are using. So I think that's it for our side.
Thanks, Yana. Anybody else have anything they want to share?
I mean, this is Catrice. I just would like to just, I just continue to be struck by the psychological impact and some of what Marilla was talking about. And the impact to the ICU nurses and caregivers, I mean, we experienced something similar to what she did on her at her hospital, where we had a nurse really whose husband was in the ICU for a long time, and that couple together hosted many parties for the ICU team. So we got to know the entire family, their grandkids, everybody. So it was like a loss of a family member to all of us. And, you know, we also had a CT tech who ended up doing really well, but after about 60 days at least in the hospital. We've had some other coworkers that were there, or families, and not only that, just some of the patients that were coming in and going through that psychological stressor of the whole visitation issue that she discussed, and being that only person, the nurse person, and being the only person at the bedside to support via a screen of some sort this, you know, kind of passing of somebody, and trying to bring them together somehow during that time. You know, I don't know what kind of research or what is out there about that, but it would be interesting to see what the impact is to our nurses and our caregivers that are going through all of this these past few months.
There was an interesting article published by SCCM, or by AACN, excuse me, from a survey that SCCM did on different aspects. It was answered by almost 300 nurses. But there was an SCCM COVID-19 meeting, virtual meeting last Friday, Saturday, which was excellent. And they had a number of concurrent sessions that dealt with COVID-19, and it was pretty inexpensive. I imagine it's going to be available online, so anybody that really would like to see that, they have like 4 20-minute sessions on proning, both ICU versus non-ICU. They had sessions on, you know, pharmacologic management, but there was some sessions on the psychological impact and those kinds of things. So that if you get in and watch the actual conference costs like $95 to hear it live, so it's pretty cheap. But I think I heard that within the next week or so, those sessions are going to be available. People could watch it, and NCS was one of the co-sponsors for the SCCM meeting.
Yeah.
So,
oh, great. Well, thanks.
But, yeah.
Okay.
Karen, I just wanted to mention something to the group. Would it be okay?
Yes. Yep.
So the board of directors is going to be considering a new committee, an inclusion committee addressing diversity, inclusion, inclusiveness, etc. And if it does get approved, it'll be a new committee that will come up probably by the end of the year. But they'll be looking for members. And right now, you know, it's an idea that came out of WINC, which is a section, but this is going to be a committee. So I just want to let people know that there'll be an opportunity to volunteer if you want to serve on a committee. And since they do need nurses and they need advanced practice nurses, so keep your eye out, because if that call for volunteers comes out, I'd like to see that they really need nurses representation right now. The way they've sketched it out, they're just using physicians from the WINC. And I said, no, this really has to be, I'd like to see they have a committee, and then they're going to have 4 subcommittees, and they're going to have co-chairs of each of those 4 subcommittees. And I said, I'd like to see a nurse or an APP be co-chair of those 4 subcommittees that they've already looking. But has to be approved by the board. I'm hopeful it's going to be approved next week, but keep an eye out for that. And also, there's a new training education committee that was approved at the last board meeting, and they're going to be coming up at the towards the end of the year. And this is really looking at training programs and certification and stuff like that. So it's different than educational products, but they're going to need nurse volunteers. So I just want to let everybody know it's a great opportunity.
Great, thanks, Mary Kay. I don't know if everybody could see the post, the chat that Rhonda posted about the trainee section, and usually there's an opportunity for mingling and networking. Anything else? Anybody else have anything they'd like to share?
Hey Karen, this is Tracy.
Hi, Tracy.
Hi. Oh, was Rhonda going to talk? Did I cut somebody off?
No, you talk, Tracy, and then I'll talk after you.
Okay, sounds good. So my role is significantly different. I'm not at the bedside anymore, but I focus on education. And so obviously with this whole pandemic, I've been doing a lot of my teaching on Zoom and GoToMeeting and at home. But I've had the opportunity to talk to nurses all over the country. And there are some common themes that I'm hearing that you guys have already mentioned. And I think we need to be prepared for, I think many hospitals are still kind of in crisis mode. And these nurses have a significant amount of PTSD. They really do. And we spend probably half of our allotted time for training talking about their experience and the trauma that they've gone through and how it has impacted them. And to the point where I'm hearing many nurses saying we are having a mass exodus of nursing staff from our institutions. People are leaving. They're burnt out. They can't handle the pressure. The stress has gotten to them. I mean, I really have to applaud, Mary Kay and Laurie and those of you guys who really thoughtfully planned for this. I'd like to think that everybody did that, but I don't know that for sure. But what I'm hearing are, units that maybe were not as well thought out or well planned, just were hit so hard with this and so incredibly stressed. And these nurses are in desperate need of follow-up in terms of, psychological issues, and they're going to leave. They're walking away in droves. I talked to one nurse from Denver. She lost 8 of her colleagues have left, and 15 more are thinking of resigning. She's like, they're going to lose their entire staff.
Are they thinking of leaving nursing?
Leaving the bedside, leaving ICU. Many of them have gone to other places. They're going to the OR, they're going to IR, they're going to the what they perceive as the less stressful areas within the institution. And it really just kind of breaks my heart to hear those stories. And I hope we can pull through this. And I think as leaders, we just all need to be aware of what folks are going through and really try to help them through that.
Good point.
Tracy, this is Rhonda Finney. Your comment about people leaving, I wonder if there are any models of rotating nurses the way you do with a police officer who works with forensics, for example. There's almost there's almost so much time that you can spend in that kind of environment before it gets to you. So I wonder if there are any models out there that would rotate nurses through different areas to help prevent that kind of burnout, because I think that would be a fabulous way to keep retention, but also keep them from burning out to the point where they're leaving and being harmed psychologically. So I think that's an excellent point, because I'm seeing that.
The various UC medical centers were collaborating on a study across all 5 centers to look at nurse stress and also family. So we're doing, it's not launched yet, but we all, I think, have approval to look at that. I think it's really significant. It's also a good path to find out about how to support nurses in terms of looking at their significant others' stress and perspective as well. So we're hoping to figure something out with that.
Deborah Tran. I was going to mention, so when we did have Ebola, we were fortunate enough to have the opportunity to ask people for volunteers first, for who wanted to work on that floor. So obviously we only got 3 patients, the patient 0 and then 1 and 2, which were staff members, but we actually had, volunteers we have multiple ICUs, so we do have that luxury because we're a larger organization, and obviously this works easier the more staff you have. But so we've, with that situation, we did ask for volunteers, and then if people had a conscious objection in the beginning, we did try to do that. We also, so then as you translate that to this situation, what we did is we had people who were donned-off coaches in the beginning, and so we utilized those people throughout the hospital who were maybe getting lower census. And so, regretfully, this was a lot of people from women's and infants, and we allowed people to have the option to, be off and use their PTO. And then if they did not want to, then they could be a coach. They weren't going in the patient's room per se. And then we also had a robust system to go through people who just probably shouldn't be in the room. So let's say you have a nurse who has an autoimmune illness and they just really don't feel comfortable with that. So we did do that, but you have to do it in a systematic way, otherwise it becomes a discrimination issue. Another element that we also employed, and of course I just lost my train of thought, the choo-choo train has gone off of my mind, but I was going to mention something else of the same nature, that you have to find a way to alter. Oh, now I remember. So we have implemented, one of our social workers who works in our behavioral health area has actually been doing a series for the nurses. And so we had already had like Schwartz rounds. If you're not familiar with Schwartz rounds, it's essentially a time where you go through a topic, not to find blame, but to evaluate a topic and allow people to share what it meant for them. So we kind of had, kind of pulling off of that, we had a social worker who worked in behavioral health talk about some tools that people could use. And what they did is, because obviously these things are usually an hour long in broadcast, and they never think, okay, well, the nurses actually can't leave their floor for a whole hour to go attend this. So they actually did tape these so that the people can actually watch them in the time that they want. We've also spent a lot of time making sure that EPA, employee assistance programs, were available. And we have not had a lot of people leave. I mean, we have a pretty regular, in and out in terms of people starting nurse practitioner school, that sort of thing. But I wouldn't say that we've had a huge boost in the number of people that have left now.
That SCC, the study that came out of SCCM, it had 6,700 nurses who responded to it, and they scored on the stress level 8 on the 0 to 10 scale. And, the key findings, exposing family members, personally being exposed, concerned about, it was highest in states where there were 20,000 cases or more. And then concerned about caring for patients with positive COVID. But it's an interesting study. If you have a chance, you can get it on. I can post it or give it to Karen if you want to see it. I think Schwartz rounds are a great idea. Actually, I was thinking about that. We haven't had one since the pandemic started, because everything got canceled. All of education, all the NLS, everything got canceled. So that's a great idea.
Well, we're over time, but anybody have anything else they want to share? Hopefully we can keep some of this dialogue going, through our website for our discussion boards and stuff, and continue to share the information. I think NCS has really been a leader at trying to gather information, particularly about the neuro aspects of things. I think as nurses, we can do the same thing. Really, thank you everyone for your time. Stay safe, stay healthy, and let's hope 2021 is better.